Okay. Is the window open now? Have you admitted people? Participants, have you admitted them?
Yes.
Okay. Okay. Ladies and gentlemen, may I welcome you all to the meeting. This meeting is anchored by Pan-African Urological Surgeons Association in collaboration with the International Society of Telemedicine and E-Health. The topic today is TeleUrology before, during, and after COVID-19 pandemic. Telemedicine has been topical in recent years, but has taken center stage following COVID-19 pandemic. Communications and meetings, including medical consultations, are now increasingly becoming virtual. This has continued to advance and perfect with technology following usage. For us, teleurology is probably the way to go. And panelists with experience in teleurology have been put together to discuss the current state and the future of teleurology and these adaptations to the practice in Africa. May I invite our revered facilitator, Frederick Levens, to introduce further the International Society of Telemedicine and what we stand for. You are welcome, sir.
Thank you very much, Emmanuel. Alexander, sorry. Just a few words on my behalf and on behalf of the International Society for Telemedicine. And let's just start from the start. Thank you again. It's a pleasure to be here with you for this webinar on teleurology before, during, and after the COVID-19 pandemic, which we are presenting in collaboration with our ISFTEH Teleurology Working Group and with POSA and other partners. Just a few words of introduction on the International Society for Telemedicine. We are basically a global network of digital health stakeholders, which comprises many national associations, national telemedicine e-health associations, healthcare providers, hospitals, home healthcare services, and others, people who are in policy and in government, establishing rules and guidelines around telemedicine and e-health. We have industry representatives within the network, researchers and educators. And one of the main things that we do and we stand for is networking and creating connections between all these different stakeholders, and in the end also fostering collaboration between all of them, between the different professions, between different continents, between different countries, and also the sharing of knowledge and experience and expertise that is around and that is there in so many countries. That's what the main aim, what we're trying to do. And well, this has really been the focus and the centerpiece of the ISFTEH in the past, but we're also working now on new services around assistance for national regulation and registration that companies who provide technologies and products in the field of telemedicine may be facing when they try to enter new markets. We're also working on accreditation programs for telehealth service providers and also professional certification programs for health and other professionals active in telemedicine and e-health. This is just a very general overview of what we do and what we stand for, but I invite you to find more information through our website. If you are not a member yet of the International Society, we invite you to join, which you can do. You can apply via the website, or for any other, feel free to email us or to contact us through the TeleUrology working group if you are already part of that or working with the group. So with this, I would now like to hand over to the chair of the ISRTH TeleUrology working group, Dr. Emmanuel Ibarra, based out of Toronto in Canada. I'll hand over to you to make your first presentation and to guide the following presentations and Q&A sessions.
Thank you.
Dr. Barr, you're muted.
So give me some time. I'd like to welcome all of you, ladies and gentlemen, from around the globe. Good afternoon, if you're in my zone. Good morning, if you're in Far East. And good evening, anywhere you are. I'd like to acknowledge my colleagues, Mohammed, Alexander, Aaron, and Fred. For the next hour or so, we'll share some information on telemedicine, teleurology, before and during and after COVID-19. This is my disclosure. For the first presentation, the objectives would be to explore some historical perspectives of telemedicine, virtual health, and teleurology. We expect at the end, we'll be able to apply the knowledge gained to initiate and grow a teleurology practice in our communities, and appraise the outcome of these teleurology virtual health practices and the needs of our communities within the next 5 years. For this presentation, I want us to look at 4 parts. Think of the historical perspective. Consider activities of telehealth, virtual health, as people, geographic barriers, and technology. Consider current state of telemedicine, teleurology, and virtual health, and the COVID-19 factor. And lastly, think of the future. I'm not going to go into very many definitions, but there are so many terms. But no matter what they are, the concepts, the definitions, the goal is improving access, building equity, providing quality care to individuals and communities wherever they are. In terms of history, telemedicine has spanned over 100 years. Very difficult to believe, but there's enough literature to support that. Every country, every region has their own story. In US, Canada, England, France, Europe, Asia, no matter where, there has been some practice of telemedicine, which will continue to grow as we continue. I picked this up from a recent book published by one of our big shots in the society, and it divided telemedicine development into tools and clinical applications. You can see, starting from telegraphy, telephone, and now to data digital transfer. And when you come to applications, there has been teleconsultation by telegraphy, and currently you can actually have self-monitoring of patients, making sure that they send their information to their care deliverers. So just to run a few things, the very first time there was some telegraphy was between Washington and Baltimore. And then we know that in 1876, Alexander Graham Bell introduced the telephone, even though currently telephone has continued to assist in virtual care all around. Now, as a medical student in my 4th year, we used to do a posting in a rural community. And in that aid, the USAID provided through IBM a system whereby the 4th year medical students, while serving in the rural community, if you have to write a prescription, it has to be approved by the consultant in the city university hospital. And so you have to go to this system, have a conversation with the consultant, and then transfer your prescription to the patient's chart. So this has been a progress all over. But there are certain milestones that I just thought I should mention. In 1959, Dr. Albert Jutra set up a telemedicine project between 2 hospitals in Montreal and made a statement that the day will come when radiological consultation for sparsely populated areas can be conducted by television instead of present question and answers over the radio. Now, in the 60s, NASA with astronauts got into space and telemedicine. However, NASA continued to develop the technology and funded several projects. But because the costs were prohibitive, this initiative was stalled. By 1972, as documented in some literature, a group of physicians set up a telemedicine service between Massachusetts General Hospital and the Boston Airport, and it's documented in archives of dermatology. By 1977, in Canada, we have the longest running telehealth project started in Newfoundland and continues until today. By 2006, we had 3 regional telemedicine programs in Ontario become the Ontario Telemedicine Network, OTN. As I said, telemedicine milestones in other parts of the world has continued to grow. In Europe, in France, in India, and every part of the world has its own story. Now, the driving force behind all this is people, distance, and technology. And these are some of the things that can happen when you develop a good network, a good system. Timely diagnosis, efficient use of healthcare providers, reduced travel time, reduced anxiety and inconvenience to relatives, increased access to health services, public health education and prevention, and more. All sorts of services can be delivered and are being delivered, as we can see with the outburst of COVID-19. There are lots of efficiencies. We should be talking about that later on. Telementoring over a distance can happen in all specialties. And I refer to you the first world telerobotic surgery service between Hamilton, Ontario and North Bay in 2005. So you can see that every time there has been some advancement through technology and human efforts. So there could be challenges, we face the challenges, and we're able to overcome them as COVID come into the system. There's funding, long-range planning, and politics, always. There are lots of efficiencies that we can get from telemedicine, and which we have derived through the crisis of COVID.
It seems we have lost Emmanuel there for a minute, probably a connection issue. I assume he will be back online very soon. I may otherwise suggest, Aaron, for you to jump in and start with your presentation. I think, yeah, that's the best to do. And then we'll get back and pick up with Emmanuel as once you are finished.
No problem.
Okay, thank you.
All right, y'all should be seeing my screen now. My talk is going to be more of a practical application of telemedicine, just to give you a little my background. I practice here in New Orleans, Louisiana, in the United States. I've been out of fellowship. I'm a pediatric urologist for about 7 years now, and one of my primary goals when I came here was to set up a telemedicine practice, actually, because we travel quite a long distance just to go see our patients. So I'll travel twice a month, still about 3 hours away, and patients will come from 4 or 5 hours away as well just to see me. And many times, as we all know in urology, the visit may be a quick 5-minute visit or a quick look at their images, and then both parties travel several hours away just to go back, and nobody's real happy or satisfied with that interaction. And so the obvious answer is typically telemedicine for the most part, because a lot of the things, especially after your initial visit, you don't need to get hands-on and actually examine the patient. And so a lot of it can be done remotely. And so that's kind of where I came from with this. Now, when I started out, obviously there's a lot of different resistance, both on billing, both on you can't do it without a physical exam, all kinds of different excuses. But one of the biggest ones I seem to get had to do with people just saying, how can I do more? Now, this picture may be more familiar to you guys and to anybody around here, but this was a trip I took to Addis Ababa, and this was the line waiting for us in clinic there. And so I know you guys are really busy, and you can see the universal look of expression of, I've been waiting in this line way too long. Please help me. And this is something we see all over the world. It's not something that's unique to here. It's not something unique to Africa. It's a real thing. You know, how could I possibly do more? And then the other thing is, does it look like I have time to play on the computer? I get that all the time. I don't have time to go sit there and play on the computer. I got patients to see. This is us rounding in that same hospital at that time, and rounding seemed to take forever. They had more patients there than I've ever seen in any of our hospitals. And so it's a busy proposition to make. So I think that the steps to succeed in this is first to really know who's your audience, who are you trying to get this to, who's going to be receptive to this, know your practice, what is your practice goals, what do you normally see, and then you just got to get started, you got to commit to it, and then don't be afraid to change. You can't, this is something that you have to be pretty flexible with at the beginning, and know that long term this is going to be best if you've accurately evaluated your office and your target audience. So what do I mean by know your audience? Well, how far is your practice catchment area? How far do you need to be reaching? What are the reasons that patients don't come to you or don't come to you in a timely fashion? What are the other options that are available in your region? You know, do you really need to be reaching past where other urologists may be, or should you focus more in on your actual area? Are your patients capable of using telemedicine technology? And that can be like Dr. Ibarra was lending before. That could be as simple as a telephone. It could be a video, audio communication. It could be a text messaging type system. Again, all things you should consider and what your patients can actually have access to and use. And then what support is available in your area to treat these patients close to home. So if there are limitations of prescribing, you know, is there someone in that patient's region that could help with that? Is there, if your limitation is the laws and who you can actually treat, do those need to be changed? Do you need to work on changing policy? Where do they need to be? All these things have to be taken in consideration to make this successful. So then the first thing, you know, we kind of did is you have to develop set criteria. And in my case, and most of the attendees' cases, what are your TeleUrology criteria? Who is it appropriate to actually see? And so you should start, in my opinion, with something that's condition specific. So are you going to see new patients, or are you just going to see follow-ups? We started with just follow-ups because we've already done the exam. We kind of know what we're dealing with, and we felt that was safer. So follow-ups are where we started, although we do see new patients now. Are you just going to do imaging reviews? Is it something you can get some images done remotely close to the patient for follow-up cancer and things like that, and then you can just do those reviews? You can. A lot of people, especially in the United States, started with post-operative care. Now, the main reason was because it's a non-billable visit for most of us, and you weren't getting paid for doing telemedicine, so it was a natural transition to just do a simple post-operative care where you weren't getting paid anyways for them to come in and provide it. But it is something that you can do for a large number of conditions where you're just checking their incisions or checking their symptoms, things like that. They may not need to come all the way back into the office if they live far away. You can also do preoperative screens if it's just merely a more detailed anesthetic history or what their medical issues are that's going to make them safe for surgery or not, or if it's just an extended counseling on do they really want surgery. Is it something that's more elective? That can easily be done during telemedicine. Cancer follow-ups, like I mentioned before, voiding dysfunction, which I do a whole lot of. In fact, we have an entire voiding dysfunction clinic, since I'm doing pediatrics, that our nurse practitioner runs by herself, where she's seeing new patients in follow-up, because the vast majority of those patients in our population have nothing physical wrong with them. They've already seen a pediatrician, had the exam, and so it's merely counseling on what they need to do from a voiding standpoint. And then on more adult-related erectile dysfunction. Most erectile dysfunction stuff you can treat via telemedicine. Then you can narrow this down even more and patient specific. So are you going to only offer it to people who are a certain distance away from your office so that you don't get overwhelmed? My personal thought on this is I have people that live very close to the hospital, but they have trouble with transportation, or they have kids at home they need to take care of. And so it's not a distance factor, it's a matter of convenience. And so I offer it to everyone, regardless of how far they live. Again, the available technology, like we talked about previously, is important. Their compliance with treatment, and this can go both ways. I have patients who are very bad about coming into the office for various reasons, but they respond very well to telemedicine. So I'm able to actually increase their adherence to our treatment plan via telemedicine. I have others, if it's a telemedicine visit, they think it's not a real visit and they won't show up. So those end up failing telemedicine, end up having to come in. Age and comfort with technology. I urge you not to completely throw out the elderly when it comes to telemedicine, which a lot of people do. They think, oh, there's no way they're going to be able to deal with this technology. They won't do it. That's absolutely not the case, and has been shown over and over again. Even the elderly are able to pick up a lot of the easy technologies these days and do telemedicine quite well, and it can be quite convenient for them. And then how are you going to deal with second, third, and fourth opinions? Personally, if they're coming in after seeing another urologist and want another opinion, I find it better patient care for them to come in and see me, because they're looking to really kind of bond with the physician, and it's easier to do that in person. So then know your practice. All right, so you have to know what you do best and use that to do telemedicine. In my opinion, telemedicine is merely to enhance the care you provide, not necessarily to replace it. So as a clinician, do you have time to see more patients? So do you have empty space in your current calendar to add on telemedicine, or are you barely keeping from drowning? Are you looking to expand or increase in efficiency, and how do you work best? And then what are your documentation requirements at your location? All of these things have to be figured out before you even start practicing. And then your support staff, do you have the resources to screen these patients? Can you educate these patients? Do you have people to troubleshoot IT? Do you have ability to advertise or market this if that's something you're going to need to do? How are you going to communicate with the outside clinicians, with their primary care providers? How are you going to give them the treatment summary that they may need? And then, of course, the legal ramifications, which are different across the entire world as far as telemedicine is concerned. And then my advice is, as many people have said, work smarter, not harder. So there are two basic models that we look at when we look at delivering telemedicine. One is what I call the dedicated model, and that's the set-aside TeleUrology blocks. And this, in my opinion, is the superior model in most urology practices, especially in very busy practices where you don't really have that extra time. And so one of the pros of this model is it's easier to manage. It's this set-aside block of time that you're just seeing telemedicine visits. It can increase your efficiency because you're not worried about other things going on. You're not worried about patients coming into clinic. You're just focusing on those patients in that list. And you can create a familiar workflow. And so your office staff knows, okay, right now we're focused on getting telemedicine patients in and out. The cons of this are it does require active recruitment. You got to fill the schedule somehow. They're not just necessarily going to come to you. So you do have to actively go out, find these patients and put them in these slots. And then you have to build it over time. So when you first start, if you have so for instance, for me, I have a Thursday afternoon telemedicine clinic. When I first started, I was seeing follow-up patients, and most of those follow-ups I see 2 months later for avoiding dysfunction clinic. When I first opened that block, I didn't have anybody in it. And so you got to account for that. You know, if your employer or if your business depends on those blocks being filled, you have to account for that lag in fill time until you get your practice up and running. Now I don't have enough time for telemedicine. They just keep filling because we have the system in place. Then there's the add-on model, which is kind of these impromptu telemedicine visits. And these are what a lot of people suggested, oh, well, if I could just throw in a patient when a patient no-shows or throw in a couple things at the end of the day, that would be more efficient for you. And so it is easy to do add-on visits. It's easy to convert your callbacks, so things you normally just call them and go over the images. And some places you can call them and convert this into a visit and actually make it a billable encounter. It's easy to increase your clinic volumes this way because you are just adding on patients. Now, again, if you don't have time to add on patients to your normal daily thing, telemedicine is not a magical cure for that. You're still not going to have time. Telemedicine still takes time, so you have to account for that. The cons of this is, in my opinion, it disrupts your normal clinic flow. And so if you have telemedicine clinics that are added onto your schedule and you already have this busy line of patients outside the door to see you in person, it really becomes disruptive. And you'll find, at least we found, that virtual patients you're seeing via telemedicine, have little actual patients. In fact, they have less actual patients than patients that are in your clinic. And part of that is because patients in your in-person clinic are trapped. They're there. They've already taken a long time to come see you. They have a much larger threshold before they're willing to walk out the door if you're taking a long time in the office. If you have a virtual patient who's sitting there on their smartphone or their computer, they probably didn't block out their day for that visit. They're also at work or doing something else. And if you're not on within 15 minutes, they just hang up and the visit's done. And so you got to be a little wary about your online patients and how long they're willing to wait for you. Then you need to look at your workflow. How are you going to really implement this? In the pre-visit workflow, you have to have patient screening, like I said before. You have to identify who you're going to see. You have to have a good intake process. How are you going to get these images that are being done remotely and make sure you have them for the time of visit? And how are you going to educate these patients? For us, we have our nurses all dedicated to doing this, and they're screening my visit right now that I have tomorrow. They're going through each of those patients, making sure I have the images, making sure they're signed up for our application and know how to use it, making sure they're appropriate for that visit if they're a new patient. And if they're not, those visits are shuffled around and moved. So by the time I get to them, I can be very efficient. And then the visit itself, like I said, I do the block scheduling. So I have a patient every 15 minutes on that block. And that clinic runs more on time than any other clinic I do, because like I said, they are counting on you to be there. They've blocked out their schedule just for a few minutes to see you, to make it more convenient for them. So you got to make sure you run on time with those. You need to have a visit rescue process, I call it. So as we've seen already in this seminar today, internet problems happen. We lose people. Well, if you lose a patient, it's important. You got to be able to get them back. They're not going to know how to just log back on like Dr. Ibarra just did. And so you got to have a process. Am I going to call them on the phone? Do I send a message to my nurse and she's going to call them and get back on? You got to figure out how you're going to rescue that visit. So we have really two telehealth platforms, one that's integrated in our EHR and one that's separate. And so we know how to quickly get them on the one that's separate, that's more reliable. And then your emergency plan. If something of an emergency is going on. And fortunately, we're urologists, so we don't see that as often as other specialties would, but you need to be able to know how to direct them. You know, call 911 now, or do you know where they're located? So you can call 911. Well, it's not 911 in Africa, I'm assuming, but emergency services, to send them directly to their home or alert their primary care provider. How do you get them the emergency care they need? And then post-visit, like I said before with Dr. Barr prescribing this, what is the prescribing process for people remotely in your area? How can you make that happen? How can you share information? You know, I always encourage a survey process to go out to these patients to make sure you're doing right by them. Are you providing the care they need? Are you actually enhancing their care and not replacing their care? So all these things you should integrate in your workflow. And then go ahead and work your plan. So go ahead, start, make your condition specific. We started with a very narrow window of certain age kids with voiding dysfunction who didn't have any other abnormalities from their pediatrician, who weren't seeking a second opinion. And that was our basic group. And we started with that, and then we expand greatly from there. And as you start using it, you start thinking, as you're seeing patients in person, you know what? They don't have to travel 5 hours to see me. That next visit, we're going to do telemedicine. And that's how you feed your telemedicine clinic, is from your own in-person clinic. Is you've thought of it, you know what's going on, you know you have the ability, and you can educate them right there. You can send them out and set them up for the visit, and you've already got the ball rolling. Then you got to commit to it. So you have to offer it to everyone capable. If you make it too narrow, you're never going to take off. You have to actively recruit them in your clinic, and don't let early empty slots scare you. Okay, you got it. This is something you got to build. Just like you built your practice to begin with, most likely, this is essentially another practice you're building. And then be sure you pivot when you need to, adjust the workflows quickly. Don't just get frustrated and abandon it, or you'll never get going. As we've seen with the COVID-19 crisis, everyone's had to pivot, adjust quickly. And we've all seen that, you know what, we can do this. This is something we can take on quickly, move and do. We went from about 250 visits a month at Children's Hospital, where I'm the medical director, and this was in several different specialties, to we were seeing about 5,000 to 8,000 visits per week during the peak. Now we're down, as we expect, as people now really just want to come in person just so they can see another human being for the most part. We're down to about 1,200 to 2,000 visits a week. So we're still seeing quite a bit more than we were before. And this really came from people being forced into using it and saying, you know what, it's not as scary as I thought. I actually can treat patients. And now they're thinking more conditions they can treat safely. And so they're continuing that on, and we're going to see a slow ramp back up. Maybe not to the levels we were before, but definitely higher than we are now. And this is kind of my personal inclination, is that I believe telehealth is health adapting. It's our responsibility, not the patient's responsibility, to adapt to the patient's need to avoid losing our role as partners in their health. And what I mean by that is, if we just let other companies take over telehealth, if we let all these providers, many of which have maybe one doctor on their entire board, go ahead and swoop in and take over the healthcare, we'll be left in the dust. We'll all be hired hands for telehealth companies, and we all know how that goes. It's not the best care. These are our patients that we see, we've been trained to see, that want to bond with us. This is what the patients want. They don't want to go to a generic telehealth company for all their care. They want to see you. They want that relationship with you. They trust you. But we have to be there for them when they see that, you know what, this other company can come to my house and see me, and I don't have to travel 5 hours. Well, we can do that too. We can be part of that. So I hope you got some practical information. I'm more than happy to share more with you guys, either individually or as the group. And feel free to email me there if you have any questions, any way I can help. But it's certainly something I'm passionate about, and something I think we can all do to help improve our patients' care. Thank you.
Thank you very much, Aaron. And we're looking for some questions. Thank you very much, Aaron. And let's see if there are some questions. There was a question about billing. How do you get paid for the work you do?
So for us, and I don't know billing in Africa, but in the United States, now with COVID-19, most insurers cover telemedicine at the same rate as they cover in-person visits. So it's been a big boon, and that's why you've seen it expand so much, especially in the United States, is because the coverage is there, whereas before it was very spotty and went from state to state or region to region. So for us, we bill the exact same way we do in-person visits with just little modifiers that let them know we did it via telemedicine.
Mohammed, you had a question. So thank you very much for the answer, I think. Mohammed? You're muted.
So another question I see is, what if you start telemedicine and you end up needing a face-to-face visit? In that case, you simply do the best you can, do a telemedicine visit and explain to the patient, I need to do X, Y, and Z, or this exam to really, truly hone in the diagnosis. And then you have, that ends up being kind of a screening visit. And that happens not infrequently, and you explain to them, I need you to come in. We don't bill for that visit if we're not providing these services. And we make sure we tell the patient that, because billing is a big thing. And so we let them know, you know what, to complete this, I don't feel like we've really done what we need to do. You need to come in for us to see you. And as far as the follow-up to that was, is the patient unhappy with the management? Rarely. I'll be honest with you. If you're able to really communicate with them effectively, bond with them the same way you do in the office, they're usually very grateful that they didn't spend all this time driving to see you, especially if it's something you can handle over the computer. So our satisfaction has been through the roof for people with telemedicine visits.
Aaron, one question for you. So supposing you start doing a video conferencing and you have a blackout like I did, and what do you do?
So generally, I call them on the phone and I explain what's going on. Because if my internet connection goes out, it's very rare that the phone goes out. And every now and then I'll have to do a phone-only visit anyways. And so recently we've had a couple hurricanes come on either side of New Orleans, basically. Most of them quite devastating, both in areas where we practice and have patients. And so both yesterday and today, I know of 2 patients where we've had to simply do phone visits because they don't have any power or any access to internet, but their cell phones still work. And so we've done it strictly through phone visits. And sometimes you have to make the exceptions for that.
Thank you very much.
Have there been studies trying to compare patient satisfaction between face-to-face visit and telemedicine? The reason why I ask that is, in our practice, unconsciously, we've been doing kind of telemedicine for a long time, like calling a patient to discuss a result, a pathology result, just trying to know how he's going, even in a non-formal way. Informal because there is no billing, we just want to catch up. But what I found is that the patient feels very valued, very like happy because of the time that is given to him. So that would be good to know if there are data supporting the patient satisfaction in these 2 scenarios.
Yeah, there's actually quite a few studies out there that look at this patient satisfaction with telemedicine, and they've all been universally high. It's in fact an area, we have a few satisfaction surveys that go out that are kind of internal that have always been high, but it's an area that personally I don't even like to publish in because it seems like a no-brainer to me. I think there's too much out there just saying, yep, patients love it when you see them at home. Well, who wouldn't? But I think there is a good point there that they do value that experience of you touching base with them, whether it's an informal or not. The advantage of our system, we actually use Zoom for our telemedicine, is I can share the images with them. And they really like that, where, I'm not just telling them the ultrasound looks good. I can pull up the ultrasound, I can draw lines around the kidneys, I can show them what we were looking at. And it really involves in the visit almost even more than when we see them in person. And so they've really latched onto that. But there is a big bias out there that a lot of people still associate a telemedicine visit as not as good as or not as valuable as an in-person visit. And so we do face that. We have patients who are perfect candidates for telemedicine, and we call them up and they'll live a long way away and say, hey, we can do this via telemedicine. And you can tell they say, well, I just don't think this is something that can be handled over telemedicine. They have no idea. It's just an internal bias that they think somebody needs to touch my child to figure this out, even if we tell them, no, that's not the case. And so I think we're going to slowly see that go away as people become more familiar with this and realize, you know, we actually can do a lot of this. And there are studies out there that show that 80% of diagnoses can be made simply on the history alone. The physical is not needed. In fact, if you give them one of these studies, if you gave them some lab findings and the physical prior to then showing them the history, and then you show them the history, they were more likely to get it wrong. So they got it right just by the history. And patients don't realize that. They think you're doing some magic when you're touching them. But as we all know, some of the things when we're just touching them is mainly just to touch the patient, so they feel like we're doing more than we actually are, and so they can feel confident in our diagnoses, when in fact we already know what's going on as soon as they tell us the history.
Thank you very much. And I think for the interest of time, we'll have to go to Mohammed. The third presentation is on benefits, barriers, and what do we do? Mohammed?
Yep. Just a second. Okay. We see the slides now?
Yes.
Okay, for this part of the talk, I'll be speaking about the benefits, and then Aaron will summarize in English. I will speak in French, and then he will be speaking about the limitation, and then I will summarize in French to cover the two audiences.
So thank you very much, Mohammed. We want to make this bilingual, and this is our disclosure.
Yeah.
Learning objectives. At the end of the session, participants should be able to list and appraise the benefits, risks, limitations, and barriers of TeleUrology. Choose risk management options for their own practice. Next slide. What is telemedicine? We've heard from Aaron, using innovative technologies to bring healthcare to patients in addition to education of healthcare professionals. Next slide. Virtual health care is here. Next slide. Benefits, risks, barriers are words we are familiar with in any type of healthcare provision. Next slide. In telemedicine, we have all sorts of diagnostic tests, equipment that we can use remotely and in-house. Next slide. The key benefits of telemedicine are it gives you more convenience and accessible care. There's potential cost and effectiveness and healthcare cost savings. There's increased engagement, better quality, and patient care. Next slide. So these are some of the benefits in addition to the generalized benefits I mentioned. Next slide. When you think of all the therapeutic aspects, these are the possibilities of services that can be given. Next slide. Specifically for patients, there's faster access to healthcare professionals, increased convenience and time saving for patients, increased equity of access to care between and within regions previously not available because of such factors as social economic factors, people who live in rural area, remote areas, and developing countries. Also, there's improved access between and within primary, secondary, and tertiary care. Overall, we believe that telemedicine, teleurology, and virtual health improves quality of care. Next slide. In terms of primary care, there's good immediate consultation with your family doctor. You can do home monitoring, diabetes, home deliveries, all sorts of health, particularly for chronically ill and elderly patients. For dialysis and palliative care, post-operative care, catheter care in long term, these are benefits that can be accrued when you have a good teleurology practice. Next slide. So overall, even for the secondary care, emergency specialist support, shared care for diagnosis and treatment, e-consult, inter and intra-hospital access are all possibilities and benefits with teleurology. Next. So for the particular urologist, like Aaron has told us, there is timely access to your patients. There's increased patient engagement, and in fact, it builds better relationships as you combine both face-to-face and virtual care. It may be cost-saving. It will help you maintain appointments and decrease no-show because the patient is given the time, you know you have the time, and everybody logs in at the same time, and that's a driving force to make patients comply. It's also very convenient. And if you do your evaluation properly, I believe it will improve your outcome and the quality of care you give. Next slide. For health organizations like hospitals and healthcare systems, we believe that it reduces healthcare costs, it reduces overcrowding and wait time in the emergency department, it reduces wait time for specialists to be seen, and overall improves quality screening and surveillance programs. Next slide. Now, distance is the issue. Northern Ontario is flourishing on telehealth and benefiting from it, and we really recommend it to all other regions. Next slide. So I will ask Mohamed to summarize in French all the benefits, and then we'll go on from there to barriers.
Alors pour les bénéfices, comme vient le dire notre collègue docteur Abara, il y a beaucoup de bénéfices. D'abord, c'est des bénéfices pour le patient liés à un accès rapide et pratique aux soins, un gain de temps qui fait que la personne connaît son heure de rendez-vous, elle se connecte, un accès équitable qui élimine les barrières de distance, les barrières socio-économiques et qui permet à tout le monde de pouvoir accéder aux soins. Et ces soins vont alors être de meilleure qualité. Pour l'accès aux soins, ils vont se décliner en accès aux soins de santé primaire. La télémédecine permet une consultation en matière de soins de santé primaire, un monitorage et un traitement de certaines affections chroniques comme le diabète, l'hypertension artérielle, un suivi par rapport aux dialyses et aux soins palliatifs, mais également des soins post-opératoires qui sont plus effectifs, et en particulier ici, la gestion des cathéters de longue durée. Deuxièmement, l'accès aux structures de santé secondaires, les hôpitaux. La télémédecine facilite les soins d'urgence, la mutualisation des soins, tant pour le diagnostic, le traitement, mais également la consultation en ligne, mais aussi un accès intra-hospitalier. Accès inter-hospitalier, ce qui permet de pouvoir suivre des patients à des structures différentes, mais également dans un même hôpital, dans des services différents. Maintenant, quels sont les bénéfices pour nous praticiens, nous urologues? Il y a un accès à temps, c'est-à-dire qui est bien monitoré un meilleur engagement des patients dans les soins, ce qui permet de pouvoir faire une décision partagée entre le praticien et le patient, une épargne de coûts, une garantie des rendez-vous, c'est-à-dire qu'on sait que tous les patients qui sont sur la liste de rendez-vous pourront être vus, ce qui également permet de réduire les absences, c'est-à-dire qu'un patient qui avait un rendez-vous et qui n'a pas pu venir pour des raisons diverses. Mais il y a surtout de meilleurs résultats et une qualité de soins plus élevée. Maintenant, pour les systèmes de santé et les organisations, il y a un bénéfice certain en termes d'économie de la santé. Il y a un désengorgement des services d'urgence et une réduction des délais d'attente, aussi bien aux urgences que pour les consultations de spécialistes, mais également une élévation, une augmentation de la qualité lorsqu'il s'agit de dépistage et de programmes de santé tels qu'on en a un peu partout. Donc, en résumé, il y a beaucoup de bénéfices, que ce soit pour le patient, pour les praticiens, mais également pour le système de santé.
Merci. Merci, thank you. So we're going to focus on barriers now. There could be technical and practical. And as you know, you've got to do some training and acquire equipment. These are time consuming. These require funds. You have to restructure your IT staff responsibilities, and this involves money, workflow rearrangements like Aaron has mentioned to us. Next slide, please. And again, this is something that you have to organize in terms of where you have your TeleUrology in the village, in your clinic, in the hospital. You can set it up anywhere, but these are challenges you have to go through. Next slide, please. As we know, all the EMRs are not interoperability. There are governance issues, licensures that may differ from state to state, region to region. And like the questions have come up, how do you get reimbursed? So these are models that are very different. And if you're going to start up a telemedicine or teleurology service, you have to look into that. In terms of medical education, what are the challenges? Do you have a curriculum to teach healthcare professionals teleurology? These are things that you need to engage your team on what to do. Next slide, please. So we talked about regulation varying from country to country. And again, some of the tools that we use in telemedicine are subject to privacy and privacy scrutinization. And there's always this issue with technology and industry that is in constant flux. They keep changing their programs. You have to buy some more. You have to budget to update your equipment to the software and hardware models that are current. Next slide. So in terms of facilitating care to remote communities, there are lots of things that you can do. And all these things required to run on software, hardware that are expensive and costly to buy. Next slide. But more importantly, something that's inherent in virtual care is that physical examination is not possible. There are no funds to establish virtual care. You may lack infrastructure. There may be no champions. And there could be a poor governance and regulatory and policy framework. Next slide. As we noted this morning, you can have technological failures. Networks may not work. These are subject to interruption, delays, system overload, and other technical glitches. Next slide. But quite important, as you begin to set your path in teleurology, virtual care establishment, you have to consider privacy, security, and confidentiality as other potential risks, barriers, and challenges that you have to overcome. Even when healthcare professionals take necessary security measures, hackers may still access electronic communication. So, as you know, PPA extends to the patient's living room. So you can't escape it. And so you must be careful as you create your program to take responsibility of preventing privacy, security, and confidentiality. Next slide. So these are limitations that we talked about. Next slide. The question you ask yourself, do you have any risk management strategies? There could be increased access in real time and data sharing, but these two factors also nurture the potential for risk exposure. So the key thing, if you have to take away anything, you have to have full disclosure to your patients. There has to be informed patient consent as you deliver the care services. Next slide. In our opinion, we believe that competencies are required to carry out efficient teleurology or virtual care service. You have to be an expert in your own case. You have to have professional ethics. You have to be a good communicator. You have to learn to collaborate with others. You have to advocate for your patients, and scholarly activities to evaluate and improve the quality of care you did. All this runs in leadership. You have to have good quality leadership to be able to organize and run effective healthcare and teleurology. Next slide. So we think that teleurology or virtual care will be a mainstream channel for Euro healthcare delivery and education. Collaborative team care, when appropriate, can be beneficial to patients and relatives will reduce risks and barriers. Thank you very much.
Merci pour résumer un peu en français les limites et les barrières. Elles sont d'abord ces limites et barrières d'ordre technique et pratique, ce qui nécessite une formation des professionnels, la mise à disposition d'équipements adaptés, mais surtout l'organisation du travail. Cette organisation du travail concerne tout le monde, mais concerne encore davantage les professionnels des systèmes d'information et télécommunications. Il faut qu'il y ait une interopérabilité entre les différents systèmes, entre les patients et les institutions, mais entre les institutions elles-mêmes. Il faut qu'il y ait des licences d'autorisation qui permettent d'encadrer cette activité. Des systèmes de paiement, de rémunération des prestations doivent également être mis en place. Mais il faut une formation médicale continue pour permettre à tout le monde de s'aligner. Mais un élément est particulièrement important quand on parle de télémédecine et qui constitue également une barrière, c'est la protection des données des patients qui est très difficile, on le sait, avec des systèmes parfois exposés. Et c'est le cas particulièrement dans le domaine de la santé mentale et des urgences, et ce qui pose un réel problème de confidentialité. Et l'accès à ces données personnelles des patients peut exposer, comme on le sait, à des poursuites, à beaucoup de complications. Et quel que soit le système informatique, il n'est pas indemne de l'accès à des hackers qui peuvent marchander ces données personnelles. Et pour pouvoir pallier à ça, l'autre barrière, c'est la disponibilité de logiciels qui, on le sait, coûtent extrêmement cher, les logiciels qui sont mis en jeu et qui font que beaucoup de pays n'arrivent pas à s'engager ouvertement ou résolument dans la télémédecine. Il existe également d'autres barrières telles que l'impossibilité d'un examen clinique complet, comme on le sait, l'absence de contact direct avec le patient, la disponibilité de fonds pour pouvoir pallier aux problèmes techniques, aux infrastructures, mais aussi les aspects de régulation, comme on l'a dit tout à l'heure, et les failles technologiques. Malgré ça, il doit y avoir des stratégies pour réduire les risques. Et ces stratégies, c'est d'abord la bonne communication, la disponibilité des technologies, mais également une communication dans le sens du consentement des patients. Il en résulte de tout ça que le message final devrait être qu'il faut qu'il y ait les compétences, il faut un professionnalisme, il faut une bonne communication et une collaboration. Ce n'est pas tout, la liste n'est pas exhaustive, mais tout ça va pouvoir être rangé dans un bon système de leadership qui permettra de mettre en œuvre cette télémédecine.
Thank you very much. There is a question from one of the, there's a question from one of the participants.
Before you move to the question, you mentioned the difficulty of physical examination. I would mention the difficulty of visiting Gorée Island in Senegal, trying out Chebujen, and looking at all these good things from telepractice. So this is just to invite you after COVID to visit Senegal and help us develop telemedicine.
That's thank you very much for the invitation to the Gorée Island. And thank you for the French component to this webinar, and we want to continue that effort. So to the question, I think one of the participants is asking whether there is a program or a curriculum in any of the universities to teach learners, medical students, postgraduate, nursing, other healthcare professionals, the art of telehealth, TeleUrology, or virtual health. Aaron, do you have any comments on that?
Yeah, so it's something we're developing a more formal policy on how to teach. Currently, we teach the physicians individually on what they need to know for telemedicine. When COVID started, we had to teach several hundred providers all at once. And so I did webinars like this, going through step by step the process and what they need to know. I have some podcasts and things out there about the softer points of telemedicine, how to engage, how to set up your camera, those kind of things. Personally, I'm a strong believer that you should try not to make this different than your in-person visits. So you should make it as similar as you can to in-person visits and not complicate it by thinking this is something totally different. And I think that's what scared a lot of people prior to COVID-19 and to getting into it, is everybody billed it as this is something totally new and amazing. It's not. It's the same thing we do every day, the same thing we're trained to do. We're just doing it over a video camera. And so really the only thing you need to learn are the individual regulations. Is there any difference in documentation based on your region? And how do you set up your camera and look into the camera as opposed to looking over the side at where your screen may be? And so those kind of things are really all you really need to know. And if you do what you've already been trained to do as a physician and how you've already been trained to make that relationship with the patient, it shouldn't be different. It shouldn't be scary. And so that's kind of been my take on it and to my hospital system.
Okay.
If I may, Emmanuel.
Fred?
Yeah, just want to point out that there is also an initiative now within the International Society for Telemedicine with some of our institutional members, universities and schools, currently in Europe, Africa, and also one in Brazil, who are or who have set up a consortium of or with their universities to look at and work on let's say adapted curricula and making sure that students but also other professionals who may want to you know, continue their education and their learning during their professional life, to make sure that some of the new things are being addressed, and certainly also what Aaron was pointing to in terms of specific regulations or licensing requirements and things like that, but also some of the practical stuff in terms of how do you conduct proper teleconsultation and things like that, that would be included, or that specific programs would be foreseen and developed. So this is something in the works that as an initiative, and as I was saying at the start of the session, the collaboration is what we really try to focus on, where different schools, different universities can come together and offer this, and also adapt it to some of the local needs, which may indeed be different between Europe, Africa, and other places in the world. So that's one thing, and well, I think the others, and Alexander may have had some comments too. Just want to point out to Mohammed that there was also a question which you can maybe answer after Alexander speaks. There was a question from one of our French-speaking attendees about how you started with telemedicine in Senegal and where it stands today. So maybe you have a few words to say on that after Alexander.
Yeah, thank you very much. The you know, the medical curriculum is always evolving, both at the postgraduate and at undergraduate level. The National University Commission in Nigeria here has a project on telemedicine. In fact, we had advanced a lot at the time I was provost some years back. They were supposed to link medical schools, and we already had links with people abroad. The main problem we still have is connectivity, to have a stable connectivity, but it's there. And I hope that it will develop faster with this issue of COVID. It has become a common place to communicate via Zoom and virtually. Then at the National Postgraduate Medical College, the curriculum is now being reviewed. And then we've noted that the telemedicine is a very big component. There are courses now we run through telemedicine and so on. So it's been incorporated in the new curriculum that we are using in the surgery faculty. Thank you.
Yeah, thank you, everybody. I think this is a good thing to continue to discuss. Mohammed, do you want to address this question to Senegal?
Yeah, okay. Do I speak in French, if you may?
Yes.
Ok. Donc, parlant de la télémédecine au Sénégal, il faut dire que nous sommes encore aux phases de début. Il y a eu certaines épouses pendant un temps essayant de faire collaborer les médecins en milieu reculé par rapport aux grands hôpitaux qui ont permis de développer certaines activités. Mais plus récemment, pour ce qui concerne l'hôpital où je travaille, il y a une collaboration avec des collègues en France qui nous permettent actuellement de mieux envisager de façon résolue le développement de cette télémédecine. Et ça commence un peu avec les consultations, où au moins une partie de la consultation est entamée avant le jour J, c'est-à-dire qu'on essaie d'amener les patients à pouvoir prendre le rendez-vous en ligne, à pouvoir faire leur paiement en ligne, à connaître l'heure de la consultation, de sorte à ce qu'ils viennent à l'hôpital à l'heure pile, ce qui permet d'éviter les foules dans les services, dans les services de consultation, ce qui permet également de mieux respecter, surtout dans cette période de Covid, les gestes barrières. Mais on ne s'arrêtera pas là. Il y a certes beaucoup de défis actuellement, notamment par rapport à la gestion électronique des dossiers des patients qui sont en cours de développement, mais il faut retenir qu'on est encore aux phases de début, mais je pense que ça devrait avancer très rapidement et nous reviendrons par rapport à ces développements. Merci.
Thank you for the comment. If you just summarize what you said in French in 2 sentences in English.
Okay, so there was a question about the development of telemedicine in Senegal. I said that we are just at our early stage. There have been a project a few years back to try to connect the physician from secondary and tertiary hospitals to practitioners in the rural areas. But this haven't moved very far at the time. And one of the challenges that we have is the development of a patient electronic medical record, which is a big problem. And one of the challenges there is the difficulty of hosting the data, you know, a kind of cloud with sufficient security regulations that protects the patient information. So that is still a big problem here. There have been development now where we have now an agency, a government agency that can do that, but still we are at the very beginning because it's very costly. All the companies that come to us to propose the solution come with very expensive bills that are very difficult to cover. But with the area of COVID, in my hospital, there is something we have initiated. And given that we cannot do the whole the process starting from the beginning to the end like Aaron is doing, we tried at least to have the patient book the appointment online, make the payment online using cell phone payment possibilities with the IT, the telecommunication system, and know the exact time of the appointment so that there will not be any overcrowding at the clinic. And this is important in the area of COVID, where the patient will come right on time to be seen and then he will go away. And that is the initial phase. And in the second phase, once we go beyond this, we'll envision trying to discuss with any patient that can be examined remotely, and then try to see how to move it. And this time there is a strong backup. I invited the doctor from my hospital, who is a general of the army, by the way, who is the doctor of our president. And just to tell you that there is a strong will this time, and we hope that there will be quick development in the near future. Thank you.
Yeah, thank you very much, Mohammed. This is something that this webinar is made for. We want all to learn from what every one of us is doing. We may not do it all the same, but innovation, great ideas, but fitting our own communities are the goals. I know we are short of time, and I want to thank all of you, your contributors, and ask the president of PAUSA and Frederick from International Society for Telemedicine to make their closing remarks if there are no other questions. And if there are questions, please contact us through the Society's website.
So maybe before we close, please, there is one question from our colleague in Cameroon, and I think that question could be more suitable for Aaron, asking what is the best way of implementing telemedicine in a resource-poor country, in a developing country?
Good question.
Yeah, I mean, I think it goes back to what do your patients have access to, and that's where you have to start, and that's what you're going to be limited to. And so if your patients only have access to reliable phone service, then your telemedicine consists of basically phone consultations. But depending on what you have is all you can do. If you don't have reliable video connections, reliable internet connections, well then you obviously can't do it that way. Now some people have come up with e-consults. There are several e-consult companies, but it's something you could set up on your own, where basically you could do the consult via email, where outside providers could email you along with the patient's chart or the patient's the basics of the patient's exam. If you worry about security, taking out all the PHI, and the specialist could provide them with a consultation that way. So there are ways around it, but obviously it's limited to what your patients have access to.
Yeah, those are very good comments, and I would like to add the limitations in developing countries: infrastructure, internet connectivity. But one thing that is really promising is the cell phone. The smartphone is a good equipment that we could, anywhere in the world, begin to look at using it to meet the needs of virtual care. I don't know if we got enough time, but I would recommend that our chairs make their final comments. And thank you, everybody, for your participation. Alexander?
Yeah, thank you very much. I think we are quite enriched following these discussions. We've been exposed, and this is one of the beginning of all the relationships that we hope to continue with. I must express our gratitude to SF, especially the chair of the SF working group, Frederick Levin, who is anchoring this program for us. I must also thank Emma for being our key lead on this TeleUrology. And our gratitude goes to Aaron Martin again, and my indefatigable Secretary General at Pausa, Mohammed. We are grateful to all of you. And we hope that this is just the beginning of what to come. Thank you. And to all participants too, we're happy because if you are not there, then we would have talked to ourselves. Thank you very much. Yeah.
Thank you indeed very much, Alexander, and thank you for the for PAUSA support of this webinar. Thank you also to all our other speakers and for your very valuable and interesting insights and experience that you have shared. Thank you to all participants for being with us, for being active and asking us your questions. It shows that there is indeed that need for the sharing of knowledge and information, which, as I said before, is what we're trying to do within the International Society for Telemedicine and eHealth. So for any other questions or things that have not been answered for you during this webinar, feel free to contact us. If you want to get involved, closer involved in the TeleUrology working group or in the International Society for Telemedicine in general, do not hesitate to contact us through the website or email address that you find here, and we'll be happy to help you and to work with you on a better understanding and a better use and implementation of telemedicine and e-health as a tool to advance healthcare and health in general. So thank you to all, and look forward to seeing you at our next webinars and activities.
Thank you, everybody. Thank you, my wonderful speakers. It's been a wonderful day. And for our participants, have a good morning, have a good afternoon, have a good evening, and good night if you were up from bed. See you next time. Bye-bye.
Bye.
Bye.
Thank you, guys. Great.